Ladies and gentlemen, the association between fluid overload and poor outcome has been highlighted throughout the last 3 days and will be talked about again in the next talk. So my role is to look at the role of extracorporeal therapies in this scenario. Here are my disclosures. None of them have anything related to or will affect what I'm going to say. I want to briefly bring you back to the bedside because I suspect that all of you have dealt with a patient like this, somebody grossly fluid overloaded. And the decision is what to do. And as you imagine yourself at the bedside, clearly there are lots of questions which go through your mind. The first and key question is, how is the patient affected? What does fluid overload do to this particular patient? And does it cause any life-threatening problems? It's also important to keep in mind that different patients obviously respond differently to different degrees of fluid overload, and those with significant comorbidities do not tolerate fluid overload as well as others. As you go through the potential therapies, you will ask yourself, what is the likelihood of a particular therapy to achieve an adequate diuresis or achieve adequate fluid removal? And with that comes the question, what are the downsides? What are the risks of choosing one therapy over the other? And finally, ultimately, the decision will be determined by the availability and the expertise in your unit. So lots of different factors to think about when facing a patient at the bedside. Another important aspect is actually underlying physiology, and I want to briefly remind everybody, although I'm conscious that the majority of you are fully aware of this. But when we're trying to remove fluid, ultimately we can only remove fluid from the vascular space, because that's what we have access to with our diuretics and extracorporeal therapies. And in order to remove fluid from the extravascular compartment, we're relying on shifts, fluid shifts from extravascular into the vascular compartment. And the ability of the body, of the individual patient, to move fluid from extravascular to intravascular varies significantly, depending on the underlying illness and acute and comorbid diseases. But ultimately, in order to achieve safe fluid removal, we can only remove fluid at the rate as the patient is able to shift fluid from extravascular to intravascular. Otherwise, the patient will become hemodynamically unstable, will drop their blood pressure, and is also at risk of other complications. So with that in mind, we have different options, and Professor Molitoris elegantly outlined the pharmacological options. On the other hand, we have extracorporeal therapies, and again, I will focus on that, but I'm conscious of the fact that Professor Costanzo already gave a whole session on extracorporeal therapies in heart failure on Wednesday, and I will try not to repeat any of the things she said. Obviously, diuretics are commonly used. We use them regularly. We know how to use them. We're very familiar with them. They're non-invasive, they're cheap, and often they work. They don't always work. But they only manage to stimulate the kidneys to excrete a hypotonic urine. And importantly, fluid removal is not predictable, and we can't really control it. We may set our target fluid balance, but there is no way we can predict whether the patient will actually respond and produce our target amount of urine. And as already been said, diuretics are associated, like any other drugs, with side effects. On the other hand, we have extracorporeal therapies, which are clearly more invasive, but they allow us to remove plasma water, what we actually want to remove. And they provide an opportunity to achieve controlled fluid removal, because we ultimately can decide how much fluid to take off per hour. In addition, fluid removal can be combined with solute removal if necessary. But there is no doubt that the initiation of extracorporeal therapy represents a big step up in complexity of care, in necessity for specialist care, and also in costs. I've already said Professor Costanzo highlighted the studies looking at ultrafiltration in heart failure on Wednesday. And I will not repeat the things she said and don't show you the slides for a second time. But there was one study which was not mentioned, and that's obviously the important CARES study. And this was an important study looking at the role of ultrafiltration in patients with acute on chronic heart failure. And there was a lot of excitement and hope that ultrafiltration would prove to be beneficial. So the investigators of this study randomized almost 200 patients with acutely decompensated heart failure and early cardiorenal syndrome to ultrafiltration versus pharmacological therapy. And the primary endpoint was a change in renal function at 96 hours, 4 days, and at 60 days. They enrolled adults with acute on chronic heart failure and evidence of acute kidney injury, as evidenced by a raised creatinine, a rise by more than 0.3 milligrams per deciliter. And the majority, well, almost all of them had had diuretics before and had persistent congestion. They excluded patients with severe kidney disease, as evidenced by creatinine above 3.5, and they excluded those who had advanced hemodynamic problems, either severely hypotensive or signs and clinical signs of cardiogenic shock, where they required intravenous hemodynamic support. They also excluded those who had signs of hemoconcentration as a result of diuretic use. And as I said, the primary endpoint was renal change in weight and renal function on day 60 and on day 4, so at 96 hours. Patients who were randomized to the ultrafiltration group were commenced on extracorporeal therapy, and the aim was to remove a constant rate of 200 mL per hour. All diuretics were stopped, and inotropes and vasodilators were not allowed. And the important thing was that the rate of fluid removal was constant in all patients. Patients randomized to the pharmacological therapy group essentially had a stepped therapy depending on response. In the first 2 days, the diuretics were adjusted with the aim to get patients to pass at least 3 to 5 liters of urine. If this failed, and they did not achieve this target diuresis, then either inotropes or vasodilators were added. They were monitored for another 24 hours, and if at 72 hours they still didn't have an adequate urine output, they were either commenced on more invasive hemodynamic support or changed over to extracorporeal therapy, either in the form of dialysis or ultrafiltration. And here are the results. The key reason for giving either diuretics or fluid or extracorporeal therapy is obviously to remove excess fluid. And as you can see here, on at 96 hours, on day 4, there was no difference in weight loss between the two groups. In both groups, patients had lost a significant amount of fluid. However, there was a difference in renal function. And as you can see here, patients randomized to the ultrafiltration group in red had a rising creatinine, a significant rising creatinine on day 4. In contrast, those randomized to the pharmacological therapy had a slight reduction, a decrease in serum creatinine. So these were all patients with early renal impairment, with cardiorenal syndrome. So the ultrafiltration group experienced a deterioration in renal function. With regards to other hard endpoints, they looked at 60-day mortality, and as you can see here, there was no difference between the two groups. And interestingly, when they looked at adverse events, there were more adverse events in the patients randomized to the ultrafiltration group within the first 60 days. So correctly, the authors concluded that pharmacological therapy was superior to ultrafiltration with regards to the effects, beneficial effects on kidney function. There was no difference in weight loss. Ultrafiltration was associated with a higher risk of adverse events, but no difference in 60-day mortality. So it was a rather disappointing study because a lot of hope had been placed on ultrafiltration in this scenario. Now, before we throw out ultrafiltration, I think it's important to look at the study critically. And there are a few important things which need to be highlighted. And these are limitations in the protocol. So firstly, patients randomized to the ultrafiltration therapy were committed to an ultrafiltration rate of 200 mL per hour, constantly in everybody. And it is possible that some of these patients did not tolerate this, where the internal vascular shifts from extravascular to intravascular exceeded or did not keep up with this fluid removal rate. It also should be pointed out that these were obviously very sick patients, and in the pharmacological group, 12% of patients had to be commenced on inotropic support, and a proportion had to be commenced on vasodilators. And this was not allowed in the ultrafiltration group. And finally, almost 1 in 4 patients in the ultrafiltration group completely failed and became so fluid overloaded that they had to be crossed over to alternative therapies. So I think these are important aspects which have, in my opinion, affected the results of the study, but these are limitations of the protocol. Now, on Wednesday, Professor Costanzo highlighted other studies in the field of congestive heart failure. So I won't comment and repeat any of them. But I'd just like to point out now and move towards the second part of my talk. I'd like to point out that the ATKI committee in 2013 decided to tackle the issue of fluid therapy. And they organized an ATKI meeting which really focused on fluids, from fluid therapy, fluid resuscitation, to fluid removal. And 2 working groups were tasked to deal with pharmacological fluid removal and extracorporeal fluid removal. There are people in the audience here, including the co-chair, who were very valuable in the contributions and, as you can see here, included in these papers. When the ATKI group looked at these different aspects, diuretics versus extracorporeal therapy, there was consensus that the key aim should be to facilitate fluid removal in a safe manner and in a timely manner. Timely in the sense that patients should be monitored for a response, and if there was no response, then therapy should be changed in order to avoid further accumulation of fluid. The ATKI group developed this figure, which you can see in one of these publications. And essentially, it takes the notion that everybody has an optimum fluid balance. And if you deviate from the optimum fluid balance, whether it's hypovolemia or hypervolemia, the outcome is worse. And the more you deviate, the worse the outcome. With regards to fluid overload, there are three main therapies which should be considered in a stepwise manner. We all felt that restriction of fluid intake should be the first type of therapy, first-line therapy, when dealing with somebody with fluid overload. The second second-line approach should be diuretics, and that was obviously already summarized. The aspects of diuretics were summarized in the previous talk. And as a third step, especially if diuretics failed, if drugs failed, then extracorporeal therapy should be considered, and it should be a crucial part of the therapy of patients with fluid overload. And I very briefly summarize the recommendation with regards to pharmacological therapy. I'm conscious of the fact that it's just been summarized only 20 minutes before. But ultimately, when we looked at pharmacological therapies, it was clear there was no evidence to tell a clinician when to start diuretics, which type of diuretic to start, and in what dose. So we left our recommendations pretty broad and said, well, if they are necessary to treat fluid overload after fluid restriction has failed, then it's crucial that clinicians prescribe them and prescribe them on a daily basis. And we felt it was very strongly that any prescription should not only have the drug and the dose, but should have clear targets of therapy with endpoints, whether that's a daily fluid balance or a cumulative fluid balance or a lactate or another biomarker, but they should have clear markers to guide the therapy and to judge response. A prescription should also have factors and parameters to indicate poor response, so that clinicians are alerted to the fact that this therapy is not working, is failing, and there needs to be a change in therapy. And clearly this can only occur if the patient gets monitored regularly and gets monitored within the clinical context, because any acute illness is a dynamic illness and new things can happen. Patients may develop a GI bleed or may suddenly lose fluid in other ways with diarrhea or vomiting. So these new additional clinical components need to be taken into consideration when prescribing diuretics. We felt that it was appropriate to give diuretics and to continue pharmacological treatment if it worked, if the target, whatever the clinical targets were, if the clinical targets were met without side effects, then it was absolutely appropriate to continue. And as I've already said, any continuation should take into account the clinical developments of the individual patient. And as I've already touched on, we felt it was very important that clinicians had parameters and factors to utilize and judge their clinical therapy and the response. And whether that's lactate or whether that's creatinine or whether it's a new biomarker, we didn't want to comment, because that clearly depends on the individual clinical setting and the familiarity of the individual clinician. But this figure here just highlights how this could be, that you monitor one factor, whether it's creatinine, and see changes and then reevaluate the therapy. And then finally, we defined pharmacological failure, because we thought this was an important time point where a switch from pharmacological treatment to extracorporeal therapy should occur. And by consensus, we defined pharmacological failure as the inability of the patient to generate an adequate diuresis to meet the clinical targets which we had set. Pharmacological failure could also be the development of adverse events, of side effects, which meant that the drug, although it may work, was no longer safe. And with that in mind, having established what pharmacological failure looks like and what it is, it's important to then reevaluate things and move over to the next step, to the third-line therapy, which could be extracorporeal therapy. So we felt that the indication for extracorporeal fluid removal was an established fluid overload which had failed to respond to diuretics, where diuretics had not been effective or where diuretics were unlikely to work, for instance, in end-stage renal failure patients on dialysis who are anuric. We felt that another indication was where patients were at high risk of fluid overload because they may need large amounts of fluid, for instance, blood products, and where there was a clinical judgment that diuretics may not be effective, would be unlikely to be effective. And then finally, the third indication being the scenario where diuretics are no longer safe, where they've caused serious side effects and should be discontinued. So by consensus, the ADKI group felt these were the main indications for extracorporeal therapy. When deciding that extracorporeal therapy is required, then the key questions are whether it should be ultrafiltration alone or whether patients also require additional solute removal. And that obviously depends on on renal function, on the overall assessment of the patient. Another question is whether this type of extracorporeal therapy should be delivered continuously or whether an intermittent approach is possible. And clearly, whether it's continuous or intermittent depends on the patient's ability to cope with the fluid removal rate per hour, and to the ability to shift fluid from extravascular into the vascular space. And a third consideration is whether to continue diuretics whilst giving extracorporeal therapy. So ultimately, the decision when to prescribe extracorporeal therapy and what type and in what format depends on the patient's individual clinical characteristics, the patient's needs, and also what's available in your unit. And I'm coming to the end of this presentation. I want to show you the fluid removal algorithm which we designed, where we said that both pharmacological measures and extracorporeal therapies have an important role. So if you think of a patient with either confirmed fluid overload or at risk of fluid overload, as shown here in the center, then the key questions are, do they need just fluid removal or do they also need solute removal? Is there a life-threatening complication of fluid overload where you can't afford to give diuretics and risk that the diuretics may not work? Are they already on a type of extracorporeal therapy so that which makes it easier to attach a second one? And finally, is diuretic resistance already present or likely? If any of these questions, if any of these criteria are met, then we felt strongly that patients should be considered for extracorporeal therapy and that diuretics did not have a role at this point. However, in the absence of any of these criteria, it was appropriate to have a trial of diuretics, obviously with regular evaluation of the response and regular evaluation of the patient's clinical developments. If you decide that extracorporeal therapy is required, then like diuretics, this extracorporeal therapy also requires a detailed prescription. And like the diuretics, it should include the rate of fluid removal, a target fluid balance, and some general parameters to guide success or failure. Obviously, if you add solute removal and add renal replacement therapy, then you would also need an additional dose to prescribe the solute removal. We also felt like, as for diuretics, extracorporeal therapy prescription should have stopping criteria so that patients are not unnecessarily exposed to all the side effects of extracorporeal therapy. And it should be monitored like any other therapy, where the success of the therapy is judged by the development and the progress of the patients using the available clinical markers and potentially tests available in your unit. So in summary, ADCI 12 concluded that there was a role for extracorporeal therapy in the management of fluid overload. And it actually formed a key component, in particular in those patients who fulfilled any of the criteria as listed here in the middle. So the need for extra additional solute removal, because diuretics do not do that, where they are at risk of life-threatening complications, simply because you may not be able to afford to wait. If the diuretics don't work, then there will be a delay and patients will become even more fluid overloaded. And in the context of diuretic resistance, either present or likely. And clearly, this is a moving task. All this can change on a daily basis, may even change during the course of the day, where patients who responded at some point to diuretics suddenly no longer respond or develop new problems, which then mean that the therapy needs to be adjusted. Thank you very much.
Thank you to you, Dr. Ostermann.